Good morning. Good morning, everybody. So we're going to switch it up a little bit this morning. Instead of listening to me, you're going to get an exciting presentation from Kristina Simonyan, one of our scientists, who's going to wow you with her science. You ready? You're up.
Well, good morning, and thank you very much for giving me the opportunity to tell you a little bit our research in the lab. I'm a relatively new addition to Mass Pioneer. I have been here since September 2017, and finally we're all set for some new studies and the continuation of previous studies. So I'm going to, first of all, want to tell you what my lab does. We're mostly focused on understanding the neural control of normal speech production, as well as neural changes occurring in patients with neurological voice disorders, such as in spasmodic dysphonia and voice tremor. We use a variety of different imaging methodologies, machine learning approaches, neural modeling, and so on. Whatever we can use in order to advance science in terms of understanding these disorders. And of course, I can't do that all myself alone, so I have quite a large team. These are present and past members of my lab, as well as a number of internal and external collaborators from around the world. And of course, funding through the NIH, Department of Defense, as well as charitable donations and foundations. So spasmodic dysphonia, also known as laryngeal dystonia, is an isolated focal dystonia, which is a movement disorder, neurological movement disorder that causes involuntary spasms in the laryngeal muscles. The fascinating thing about spasmodic dysphonia is that it is very task-specific. This means that symptoms occur only during speaking, but not during other types of vocalizations, such as laughing, crying, even singing is not affected to that degree. So because of this discrepancy in symptoms, this disorder has been considered for many years as a mental condition, and patients have been wrongly diagnosed and wrongly treated, which added to their quality, decreases of their quality of life and overall expectations. So there are different so-called clinical phenotypes, in other words, different forms of spasmodic dysphonia. The most common form is abductor spasmodic dysphonia, during which there are spasms, involuntary spasms in the laryngeal muscles during closing of the vocal folds. And patients sound very, their voice breaks on vowels. They sound with a very harsh voice quality and with a lot of struggle while they're speaking. An example of a patient is here.
Has a rabbit in his hat. Akron to get apple for Sally. And patted the fat lamb.
What?
And will catch a cold if he doesn't have a hat. Jack set on attack.
So as you heard, there's a lot of struggle to push air through the spasming vocal folds, and there are breaks due to these spasms in the muscles. Less common form of spasmodic dysphonia is abductor form, where spasms occur in the opening muscle of the larynx, and that keeps vocal folds apart from each other. And in this case, there are again voice breaks, but they occur mostly on voiceless consonants, and the quality of voice is of more breathy character. For example,
Hungry.
oh. Where did it go?
He's hiding behind the house. Hurry. Helen is far ahead. He has gone home because he is hungry.
Like H is affected, P's are affected, S's are affected. There are possibly also different genotypes. We don't know what are the genes responsible for this neurological voice disorder. About 16% of family members have dystonia too. So life toll of this disorder is quite a bit significant. Here is an example of what it may mean.
So it's hard to explain to anyone who hasn't lost their voice what that's like. I think everybody can imagine what it's like to be blind. You know, you close your eyes and try to walk around the room. What's it like to be deaf? You can kind of imagine those a little bit. But losing your voice, and in this frustrating way, which is words come out, they're just hard to understand. So you can't have a normal conversation in any kind of a noisy environment. And what that does is it's almost like being in an iron lung. It's like you're a prisoner in your own head, because you want to talk, you want to interact, you want to be part of the action, you want to relate to people. You just can't. I woke up every day during the worst part of the spasmodic dysphonia and thought about killing myself. I'm literally killing myself because life just wasn't worth it. Probably the most annoying thing about having spasmodic dysphonia was trying to order at a restaurant. And I can't tell you how many times I got the wrong meal. Now, at the time, I was drinking a lot of Diet Coke. And I would always ask for a Diet Coke. The first thing when the server came, I'd say, can I have a Coke? And usually they'd say, Coke? And I'd say, Coke. And they'd say, Coke. And I'd say, Coke. And they'd say, Coke. And, you know, I would get so many Cokes when I wanted a Diet Coke that that was unusually frustrating.
So,
has a rat in his hat.
Hurry.
Backward.
Helen's.
Okay, so what complicates this disorder even further, that there are no diagnostic, objective diagnostic measures. Everything is based on the physician's experience, and if patients are lucky, they get diagnosed sooner than later. However, there is no consensus between physicians on the diagnosis, and their current agreement rate is at 34%, which is well below the chance level of 50%. This leads to delays in diagnosis and treatment, symptom management of this disorder, on average for 5.5 years. So with a person with voice disorder, which is rare, nobody heard of these symptoms before, and so on, and person is thinking, you know, I'm going to die of this disorder, I don't know what's going on with me, and there's nobody who can derive correct diagnosis. So can we use any of our current knowledge about the mechanisms of this disorder development to build helpful diagnostic objective tools that can not replace physicians but help them in their decision making about the diagnosis? And I'm skipping the whole, you know, many years of research that went into looking into these disorder mechanisms, just to give you some ideas of where we're going with our research. So, and a summary of this research is shown here. We did a meta-analysis of several studies that looked into brain abnormalities, since this is a neurological disorder. We looked into brain abnormalities to identify common changes, and we used this with machine learning to derive some objective measures of diagnosis. So, as you see here, we had structural MRIs. We fed it into a machine learning algorithm. We had 2 different pipelines, and we arrived to some sort of diagnosis, which was not physician-based, was machine-based. So to show this a little bit in further detail, here you see input of brain scans and our use of common knowledge about disorder pathophysiology, which was followed by the use of different machine learning algorithms, linear discriminant analysis, support vector machines, and neural networks. As well, in parallel, we use so-called semi-supervised pipeline, where we had very little manipulation of images. Basically, we fed machine learning algorithm only brain scans. Meaning that we wanted to see how comparable these classifications between disorder and normal state can be. So as a reminder, the agreement rate between physicians is 34%. Our machine learning algorithms were able to identify and discriminate spasmodic dysphonia from normal states at the accuracy between 68 and 72%, which is double of physicians' agreement rate. So where we're going with this, we want to build software, and we're working on it, that we can have it implemented in clinical practice. For example, it's a cartoon of a possible scenario where a patient comes to a doctor to see ENT or a neurologist with symptoms of disorder that may be resembling spasmodic dysphonia. And the physician orders MRI, which takes 5 to 10 minutes probably to obtain, then consults the machine learning algorithm, which is built on all the knowledge coming from the pathophysiology of spasmodic dysphonia and processing of data set that is going on in background, and get an approximate accuracy of what it may be, whether it's adductor spasmodic dysphonia, abductor, or it may be healthy subjects or other voice disorder. So, and then a physician will make a own decision about whether he or she agrees with the algorithm or not to deliver the final diagnosis. So this is one of the research areas that we are moving forward to help deliver software tools that will aid with clinical decision making. The other area of our interest is to develop novel treatment options for this disorder. Currently, these patients don't have any targeted treatment for their voice symptoms. Botulinum toxin injections into laryngeal muscles are used to alleviate symptoms temporarily. However, the effect wears off within 3-4 months, so they have to repeat injections every 3-4 months for life. In addition, not every patient does receive benefit. About 40% of patients do not receive any benefit, and injections into the laryngeal muscles affect other behaviors, for example, swallowing and breathing, which results in a number of additional side effects. There are no oral medications targeting spasmodic dysphonia. Some patients report some anecdotal benefits from lorazepam, clonazepam, and so on. Some receive antidepressants and anti-anxiety drugs to cope with disorder-associated depression and anxiety. So it was a curious observation over the years when my patients started noticing that a glass of wine would help their symptoms. And first I thought, a glass of wine helps everyone. But then I realized that it's kind of a pattern. So we started asking more targeted questions: how much alcohol you drink, your friends and family, do they also notice that, it helps your voice symptoms? And we ended up doing this online survey where we included over 600 patients over a 3-week period, and we asked a number of voice problem questions, including the effect of alcohol. What we found out that more than half of them, more than half of our cohort, which was 406 patients with diagnosed spasmodic dysphonia, had positive effect of alcohol. And this was also confirmed by their friends and relatives, unless they were drinking together, I don't know, but it seemed to be reasonable looking at the percentages and the reports. They also reported that the duration is about 1 to 3 hours, and they would need on average two drinks. So thinking about alcohol, we don't want to prescribe alcohol as medicine, I suppose. So we thought, okay, what we can do to have the effects of alcohol, but not really have patients take alcohol. And by the way, many patients self-medicate with alcohol, especially if they have some events they need to attend and their voice improves. So that's really not practical thing to do. So sodium oxybate is a gamma hydroxybutyric acid, which mimics the effects of alcohol. It is ingested orally, it's a solution, and it absorbs very quickly, crosses blood-brain barrier, which means it has central effect, and it converts into GABA within the brain. It's an inhibitory neurotransmitter in the brain, which is deficient in patients with spasmodic dysphonia as well as with other dystonia. So it's like hallmark feature of dystonia. And it is approved by FDA for cataplexy and excessive daytime sleepiness in narcolepsy. So this is offline indication for spasmodic dysphonia, but we conducted a study where we included 28 patients with alcohol-responsive, self-reported alcohol-responsive spasmodic dysphonia. We gave them single dose of 1 to 1.5 gram of sodium oxybate diluted in water. And we found that it is effective in nearly 74% of our patients. The drug effects were observed within 30-40 minutes. It's fast-acting drug. They lasted about 3.5 hours, which usually good for people to get through whatever assignment or conference or speech or whatever they have. They can retake the drug during the day, and they can use it as needed. So if they don't need their voice really over weekend, when they are at home in comfortable environment where their symptoms already are getting better, they really don't need to take it. And the side effects were limited. About 40% of patients had side effects, and they were quite mild, including mild dizziness, lightheadedness, and headache that resolved within 45-60 minutes. So these are one of my last slides, and here I want to show an example of the treatment effect in a patient with spasmodic dysphonia.
He is hiding behind the house.
He is hiding behind the house.
There's a lot of breaks on H's.
Helen is far ahead.
Hurry, Helen is far ahead.
He has gone home because he is hungry.
He has gone home because he is hungry.
I have a friend whose home is a lighthouse.
I have a friend whose home is a lighthouse.
So quite severe spasmodic dysphonia. He had lost his job. He was on disability and really didn't know what to do with his life. So brain activity, since this centrally acting agent, looked quite extensive. This is above normal levels. And here is an example of him saying same sentences 40 minutes after treatment.
He is hiding behind the house.
He is hiding behind the house.
Hurry, Helen is far ahead.
Hurry, Helen is far ahead.
He has gone home because he is hungry.
He has gone home because he is hungry.
I have a friend whose home is a lighthouse.
I have a friend whose home is a lighthouse.
So in the first video, you saw that he was really struggling to say even simple sentence. In the second video, he was quite bored with us, asking him to repeat all this stuff. And amazingly, his brain activity was normalized, almost normalized to the levels of healthy subjects. And putting this together in a group, you see these are differences between patients and healthy subjects. So wherever you see orange or red looking blobs, they show additionally increased activity in patients compared to healthy subjects. So following the drug, you see the most of these abnormalities are gone with only 1 or 2 regions remaining still abnormal, but not to the effect as it was before. So that was my last slide. Thank you very much.
Questions? Thank you very much.
Thank you very much.